Before I start my talk, I want to express my special thanks for the committee to inviting me here. I'm very much honored. I come from Israel. I would like to present a case of a popliteal avulsion fracture, an isolated popliteus tendon avulsion fracture. I have no financial disclosures. Popliteus avulsion fracture incidence is very rare. It is usually combined with posterolateral corner multidirectional or multi-ligament injury, and the popliteus avulsion without a bony fragment is even more common. The first case is a 17-year-old male who had a twisting injury falling from a bicycle. He came to us with a locked knee, and the X-ray raised the suspicion of a loose body inside the bone, inside the knee. The CT revealed a popliteus avulsion fracture with displaced single bony fragment. The patella and the condyles were intact. We have confirmed this diagnosis with an MRI, which also precluded menisci or cruciate ligament, LCL, MCL, popliteofibular ligament, or MPFL. They were all intact. My first question to the ARS is whether to do a conservative treatment, remove the fragment, arthroscopic reinsertion, or open reinsertion. Can you put the first ARS, please? I see most of the people would like arthroscopic or open reinsertion, and that is what we have decided to do. We started with arthroscopy. We saw the avulsed fragment. It was identified in the lateral guttural extension, looking from the inferolateral viewing scope. And then I've switched the portals to a superolateral working port and an inferolateral working port as well. After 20 minutes of trying to refixate it and hold it, I gave up and moved to a mini-open arthrotomy. That was done anterior to the lateral collateral ligament. The tendon was moved out of the joint. The tendinous part was whip stitched with an orthocord wire. An image intensifier helped me in order to assess all epiphyseal attachment sites, and a knotless helix reattachment of the tendon. This is the helix refixation, all epiphyseal attachment site. A post-operative, reattachment arthroscopy revealed that the tendon was attached and good tension. Post-op x-rays did not show any problem, and after 3 months, the patient had good stability, AP medial lateral, negative dial test, and full range of motion. This is MRI post-operatively, 3 months afterwards. Continuous popliteus tendon, the physis was not involved. I've done some literature research. There were several case reports, one done by Bob Marks in 2022 of a patient, 31-year-old, who had chronic popliteus avulsion fracture 18 years earlier, who was treated then conservatively, and then he came to them with a locked knee, and the fragment was excised. Another case report from Saudi Arabia, Also a case report of an isolated fracture where no gross distal retraction was seen, therefore conservative measurement was done, as well as in this case report. However, Stephen Halen from Belgium did a systematic review and found out about 38 patients who had the same pathology. 63% of them were treated operatively, 24% were treated conservatively. My conclusions from this pathology is that it can be treated non-operatively. The indications for surgery are failed conservative treatment, locked knee, or involvement of the physis. And we should be aware that there is a risk of physical growth disturbance if we treat it wrongly. However, in the absence of ligamentous instability, treatment may be conservative.
Thank you. Any questions from the house? So I would like to ask from the panelists, do you have any experience of isolated popliteus rupture in young patients with a cruciate ligament injury? And if yes, then how to diagnose it clinically?
So yeah, we were just having a chat on the panel here actually. I've seen exactly the same of an isolated Popliteus avulsion in a 13-year-old. And I did exactly the same as you, but I went straight to open. I didn't think I was technically gifted enough to do it arthroscopically, so I opened it, put a small anchor in. They're really difficult to pick up with children in particular, isolated pain. Getting the examination can be a challenge with just an isolated Popliteus avulsion. But I think on MRI scan, you see the X-ray. This one had a small slither of bone.
So I'm asking, it's not for the adolescent. I'm asking in the adult patient, the skeletally mature patients. Anyone has seen isolated popliteus ruptures? And how to diagnose them clinically? Milind sir?
How to diagnose? There are no classical clinical signs. The patient presented, she was a 35 years old lady with a twisting injury, presented with lateral sided knee pain and marked tenderness over the lateral joint. So thinking that she has a lateral meniscus tear, I sent her to the MRI scan where it was incidentally diagnosed with a popliteal avulsion. I required it arthroscopically by moving my scope into the lateral gutter. The tendinous part was still seen in the hiatus. Got hold of it in figure of 4 position. Popliteus has got good excursion, so I could pull it out into the lateral compartment, whip stitch it, and then from outside in fix it in the superficial action.
Yeah. Sheetal, any experience on this? Not at ankles. So it's more common in adolescent age group to see.
If there are no comments, I would like to proceed with another case. Is that okay?
Huh?
Raju said it's okay that I club 2 cases in one presentation.
He has another case. Didn't go
Okay.
The next case is a complication of mine, a nitinol breakage of the tibial inside the tibial canal. And what do you deal with that? How do you deal with that? Well, my scenario is the worst case scenario. You perform an ACL reconstruction. I usually use hamstrings as my graft. Femoral fixation with an adjustable loop button. Tibial fixation with an interference screw and a staple. I usually use a staple as well. The operation went well. The next day, post-operative X-ray, whoops, there is a nitinol guide inside the tibial canal, and we're 1 day post-operatively, and this is my ARS question. Would you leave the nitinol and again X-rays? Would you remove the screw in the nitinol? Would you do a full revision? And the other question is, who have had such a complication?
So before we take this question, can we have a raise of hand? How many of us are getting routine X-rays post ACL reconstruction? Majority of us. I'm not getting it done, so I'll start doing it.
Well, Himanshu, I didn't have to used to do that regularly, but after I had this trouble, now I do it every time.
Yes, that's what I thought.
We did a revision arthroscopy the next day, after informing the patient, of course, what happened. At the beginning, the graft on the tibial side was secured with an orthocord whip stitch because there was some remnant aside from the tibial canal. The screw was removed, and if you look quite over there, you see that the screw is not in the exact position. The screw is basically off the canal. This may have caused the nitinol to break. Then the nitinol was removed from the tibial canal with an image intensifier and a grasper through the tibial canal, and a Healy knotless secured the tibial part of the graft. These are the post-revision X-rays, and this is 7 months post-operatively with an intact ACL, and the knee is stable. And my conclusions, my take-home message from this incident is, when you're using a guide, remove it once the screw is engaged, and examine your guide wire once you remove it from the knee. Have 2 guide wires to compare, so that you know that if you took the guide wire and it broke, part of it is inside the knee. And when in doubt, have an image intensifier to look in the knee. And it is better to deal with this complication right away and not the next day. Unfortunately, several weeks after this incident, I had the same incident. However, this time I was prepared. Therefore, at the same occasion, I went in, I saw it, and I took it out. So my take-home message worked for the second time.
So maybe change the nitinol company.
Thank you.
Are these reusable wires? Out of curiosity, are these single-use wires, or are they reusable? We're just curious why they're breaking.
I don't want to say which company it is, but I think those needle wires are a bit weak.
Okay.
I don't think my technique has changed, but they are weak.
So any questions from the house till now? But this morning we have seen 2 complications, an endo button lying inside the tunnel, and now this broken nitinol wire. So those who are not getting their X-rays done will probably start getting the.
This is exactly the take-home message.
Exactly.
That thing I do exactly for me. Always keep 2 things of the screw, 2 wires of the same size, and I always ask my assistant to check for the completeness after removal. And after the screw has engaged, back out the nitinol wire. The chance is much less. And if in doubt, see them.
Himanshu, you are quite convinced now. You want to get your X-rays done post-op.
Yes.
I think Himanshu, the biggest reason for this is if you put your nitron wire in a flexion, and sometimes that nitron wire is a little bit in the joint, then you do the extension, then you try to put your screw. So that is the time the guide wire will bend inside and it will break.
Yes.
So then putting the guide wire in the extension, putting the screw in the extension.
And I think if you are getting any trouble in tightening your screw, that means your guide wire is already bent. You should remove it and change your guide wire. ID?
So just if we just do your technique like just engaging the screw and then completing the screw into the tunnel, how many times have you seen that there is a screw diverging away from the tunnel or going to the soft metaphyseal bone if you are doing it without a wire? Have you ever noticed it? I have seen it a couple of times in my own patients. When I use this, I just engage the screw and take out the wire. The screw can diverge away from the tunnel.
So I think it's once your half of the screw is in, you should ideally remove it. This is what I think.
So
What's wrong if you put the whole screw in and then remove it?
I've started holding the wire inside. Yeah.
So I think again the
Huh?
ideal what he's pointing out, the problem it happens because if your graft at the end of the TPI is not covered completely with the good fiber wire suture.
Bend क्यों हो जाएगा?
So that fiber wire offers the resistance to your screw. So if it is not there, if you try to put your screw and your guide wire is out, that screw is going to change the direction. So at the end of the tunnel, if the fiber wire is tightened very well, then it is going to act as a resistance to that screw.
Well point taken.
So you
All-
can hold the.
Chirag.
Sheetal sir, also to add on, the whip switches which we put, no? Sometimes your wire can go through that, and that bends your screw, your wire, when you're putting the screw, and then you're unable to pull it out.
So I think we can discuss this, how to put the screw later on. So we close this talk now. Thank you, sir.